Hello students, in today's session let's discuss about metabolic syndrome. So the metabolic syndrome or earlier called as the syndrome X or the insulin resistance syndrome, or it was described by Reaven, so it was called as the Reaven syndrome. So it's a constellation of various metabolic abnormalities which has a direct cardiovascular risk that is there, and also has an important risk factors for development of diabetes and its complications. So you have diabetes, you have obesity, you have dyslipidemia and hypertension together, and that composites of the metabolic syndrome. So the most important risk factor in metabolic syndrome is the overweight or obesity. So this was the most important factor that came up with the worldwide pandemic of overweight and obesity that's happening. This is the driving force of the metabolic syndrome, especially the central adiposity. So if you see the waist hip circumference or the waist ratio, hip ratio and the waist hip circumference, that is the one which is getting the highest risk factor that is there. The other risk factor is the sedentary lifestyle, which results in various components, like it has the increased chances of adipose tissues, there is reduced good cholesterol, there is a higher chance of triglycerides, high blood pressure, and obviously chance of getting diabetes in genetically immune. So sedentary lifestyle is an important risk factor that is there. So compared to people who are more mobile, the chance of developing metabolic syndrome is 4 times higher in patients who are sedentary. So they did a simple analysis of people who would sit and watch TV for less than an hour a day to ones who are having the same behavior more than 4 hours a day. They found that almost 2 to 2.5 times risk was higher. The next important factor that's coming up, which is non-modifiable, is aging. So aging is a direct correlation as the people are going more than 50 years of age. So the US population, they say 40% of people above the age of 50 years have metabolic syndrome. So it's an independent criteria. Coming on to the diabetes, or an impaired glucose tolerance are an important component of metabolic syndrome, because the basic risk factor of metabolic syndrome is insulin resistance. So the patients do develop type 2 diabetes as a risk factor. Now this all together, along with blood pressure, has a high chance of coronary artery disease. So almost 50% of patients with coronary artery disease do have metabolic syndrome, and 37% of patients with metabolic syndrome have developed coronary artery disease. Now this correlation is very significant, especially in younger people, the ones who are females who are protected and who do not have a strong family history. You do find a lot of coronary artery disease that you see them in them. Again, you see that this conglomerate of symptoms that are looking at, you have the prediabetes, you have the atherogenic dyslipidemia, that is the increased LDL, decreased HDL and the increased triglycerides, the high normal BP that you see there. So this is an important conglomerate that you see there. Also remember, you could have certain genetic predisposition factors, like you could have the lipodystrophic syndromes. So you have various syndromes where there is visceral obesity. You could have the Dunnigan's familial partial lipodystrophy, the Bird-Neal-Seep congenital lipodystrophy that is there, the acquired, which could be due to HIV or the drug-induced hyperlipid. All of them are associated with insulin resistance and a direct risk factor for development of a cardiovascular risk. So the root cause of all this in metabolic syndrome is insulin resistance. So that is the unifying hypothesis which describes the entire pathophysiology of metabolic syndrome, that is insulin resistance. So postprandial hyperinsulinemia is the one which starts first, following with fasting hyperinsulinemia, and then there is the classical hyperglycemia that happens. Parallelly, we have the increased free fatty acids that is going up there. So that will increase the triglycerides and LDL, and then the tissue lipoproteins are broken down. So there is a lot of lipolysis that's happening there. So all of this put together, there is a metabolic stress that is created, and they are going to develop all the complications of metabolic syndrome that you would see. The other important measure is the visceral obesity. So how do you measure the visceral obesity? Is the waist circumference. So the increasing waist circumference is a direct relationship to insulin resistance that you see there. So you can measure it clinically, or you can have CT MRI to actually look for the visceral adipose tissue. Now that is the one which is predisposing, especially the Asian population compared to the African American population. The visceral obesity is much higher, and this is the adipose tissue which is causing all the problems that you see there. Coming on to the risk factor of dyslipidemia, so the free fatty acid flux to the liver is associated with the increased ApoB containing triglyceride rich lipoproteins, especially the VLDL that is there, that is one which is there. But very important is isolated hypertriglyceridemia is a very strong risk factor for development of complications that is there. Also, there is a reduction in HDL and an increased LDL that is there. So this is what we call it as the atherogenic dyslipidemia that you commonly see in patients with metabolic syndrome. So the bad triad that you see there is an increased small density lipoproteins, that is the LDLC, the increased triglycerides, both fasting and that is the increased large VLDL, and there is a decreased HDL cholesterol. So in contrast, you find both increased non-HDL cholesterol which is increasing, as well as the ApoB that is very much increasing that you see there. So the small density particles are decreasing, the large density particles are increasing, and that is where you do have this very characteristic atherogenic dyslipidemia that you see there. Again, remember the triglycerides also have the cholesterol content, both VLDL 1 and 2 both are present, and these are the ones which drive the atherogenic process that you see there. So if you look at the entire proportion of you see there, if you see the triglyceride content will be higher in kilomicrons, followed by VLDL 1, 2, the intermittent lipoprotein, and then the non-atherogenic proteins that you see is the HDL, which have a very small content of triglycerides that you see there. So the more the triglycerides, you have more kilomicrons which have the APO and the VLDL and the intermittent lipoproteins that you see there. The next important feature that you have is the glucose intolerance. So it may not be frank diabetes that you see there. You find impaired glucose tolerance, that is either the impaired fasting glucose, or you could have the postprandial hyperglycemia that's there. So this is what onsets, and eventually you go into frank diabetes. Hypertension is the other key pillar that is looked at. So under physiological conditions, insulin is a vasodilator with secondary effects of sodium reabsorption in the kidney. However, in the setting of insulin resistance, the vasodilatory effect of insulin is lost. Also, the sodium reabsorption is preserved. So what happens? There is a vasodilatation, but the sodium reabsorption is increasing. So there is a secondary hypertension that you happen. Again, remember the insulin resistance that is seen there. There is characterized by the impairment of the phosphatidyl inositol 3 kinase signaling, and that results in excursion of endothelins. So endothelins is going to increase, and that is going to add to the hypertension risk in these patients that you see there. Again, remember, when there is an insulin resistance, it's a pro-inflammatory state. So large number of inflammatory cytokines are increased, like the interleukin 1, interleukin 6, interleukin 18, the resistin, the TNF alpha, the C-reactive protein, all of them are overexpressed in the adipose tissue, and these have both, the adipose tissue has both paracrine, autocrine function that's there, and they are going to drive the atherogenic potential that you see there. The important mediator that has been studied specifically is the adiponectin. Now this is a cytokine which is released from the adipocytes. So it actually enhances the insulin sensitivity and inhibits the inflammation. So in the liver, the adiponectin inhibits the expression of gluconeogenic enzymes and the rate glucose production. In the muscle, the adiponectin would increase the glucose transport and enhance free fatty oxidation. Now adiponectin is reduced in metabolic syndrome, and that is why you have the imbalance that's happening between the pro-inflammatory kines with the adiponectin that is seen, which is impaired in these. Now, coming on to the clinical features, as we said, they do not have any particular feature. The most important features they'll have is obesity in the form of a high BMI or the high waist hip ratio or the waist circumference is increased. They will have hypertension, the blood pressure will be higher. So, these are two important features they can have. They can have clinical signs of insulin resistance in the form of acanthosis nigricans, acrocordons, they can be there, and they may be predisposed to develop other things. They may have obstructive sleep apnea as a feature that could be seen there. You might find lipoatrophy, lipohypertrophy that you could see there in these patients. So, as we said, there is hypertension, the blood pressure will be higher, pre-diabetes or diabetes, atherogenic dyslipidemia, along with impaired kidney functions, fatty liver disease, that's what is coming up. So, NAFLD is increasing. These patients are prone to develop heart failure with preserved ejection fraction. Obstructive sleep apnea is a direct correlation. PCOT, there is a sympathetic activation and tachycardia, hyperuricemia and chronic inflammation that's happening. So, all of them will eventually result in complications. So, as this keeps increasing, you would find that there is a increased pulmonary pressure, the LA dilatation that happens. They are prone to develop atrial fibrillation as a sequence there is. Also, there is a LV diastolic dysfunction that happens. Also, there is a concentric LVH that you would see there. So, if you look at the normal body weight with the increased body weight that you are seeing here, as the obesity increasing between 30 to 50, you would find that the PCOS and inflammation starts, hyperuricemia, high blood pressure, atherogenic dyslipidemia, sympathetic tachycardia keeps increasing. As it crosses 40 to 50, you have hypertension, diabetes and obstructive sleep apnea which is going to, and moment it crosses 50, you know that there is a heart failure, NAFLD and impaired kidney functions that's happening. So, this is a direct relation that is seen in these patients that you'd see. So, diagnosis, basically we have the clinical conglomerate. So, clinical examination, you will want to do the other investigations. So, you will do the fasting blood sugar, the HbA1c, the postprandial blood sugar or an implied glucose tolerance test. You will do the fasting lipid profile. These are basic investigations to be done. You can do the ApoB level, HSCRP, uric acid, urine albumin and the liver function test. Also, these patients can have OSA, so they can require to do a polysomnography, and PCOS has to be ruled out. Now, these patients, as we see, the clinical definition is by either obesity or BMI more than 30 kgs per meter square, a waist circumference of more than 88 in females and 102 in men. So, that's what we call it as, along with either pre-diabetes, that is the fasting more than 110 or 140 after 120 minutes of glucose tolerance test, HbA1c of more than 5.5, or the patient is already on treatment of sugars, then it becomes this. Elevated non-HDL cholesterol, that is the non-HDL cholesterol more than 130, or the patient is already on treatment, or a high blood pressure, systolic more than 130, diastolic more than 85, systolic more than 130 or diastolic more than 80 if home measurement is there, or the patient is on treatment. So, if the patient has obesity and meets one of the two criteria or two of the three other criteria of these, then we can consider these patients to be having a classical metabolic syndrome. So, we see these patients, once we have understood these patients, we would want to make sure that whether diabetes is there or IGT or FGC. So, if you find the HbA1c is more than 6.5, straight it becomes diabetes. If the RBS is more than 126, again it is diabetes. If the HbA1c is less than 6.5 and the fasting is between 100 to 125, do the OGTT. If the OGTT shows that it's more than 200, it is diabetes. If the OGTT is between 140 to 139, we call it as IGT, that is the imposed glucose tolerance, and the blood glucose is less than 140, then it's only fasting glucose which is high. So, that is what we call it as a IFG. So, based on the glucose tolerance test, you can make out whether it's IGT or IFG that is there. So, blood pressure has to be recorded, very important, both in office and ambulatory. The fasting blood glucose and the HbA1c, the lipid panel, especially the non-lipid. Do an oral glucose tolerance test if you find that the sugars are on the border. Serum creatinine and the urine protein, albumin creatinine ratio. An abdominal ultrasound, the ALT, AST and platelet count for look to the liver disease. The serum uric acid. You might require to do the echocardiography. You can do the fibroscan for the liver now. You don't have to do the biopsy. Polysomnography, very, very important for OSA, and androgen levels and pelvic ultrasound following for PCOS that you see there. So it's very important for us to understand that, and we label it and identify all the possible parameters that are there in a particular patient with metabolic syndrome, and then we have to look into modification. So obesity, impaired glucose tolerance, hypertension, dyslipidemia, very, very important. Start with diet. So diet is the most important. So you have to have weight reduction. So make sure that the simple carbohydrates is decreased, trans fatty acid is decreased, omega-3 fatty acid increased, decreased salt. The calories decreased at least by 500 to 600 kilocalories per day, and physical activity of at least 150 to 300 minutes for a week has to be advised. Smoking cessation, alcohol cessation, and sleep hygiene has to be advised. So this is most important. After that, look for, if the BMI is very high, if the weight loss is not gained that well, you can suggest them to do either a GLP-1 receptor antagonist. Later, you can try orlistat or naltrexone bupropion combination. And if the BMI is very, very high and the patient has other comorbidities, you can suggest them metabolic surgery. For the sugars, if the patient has done a good lifestyle modification and still it is high, you can start them on either metformin or the GLP receptor agonist. Next drugs that we are doing is the SGLT, only then we'll add the other. Now, if the BP is a little higher, the best drugs that we use is ACRB plus or minus chlorthalidone or calcium channel blockers. And if it is still not controlled, you can add aldosterone antagonist or beta blockers. Very important is the dyslipidemia. Even if the LDL is not very high, but it is more than 50% of the non-HDL there, statin has to be started and increased to the maximum tolerated dose. If still not, add azithromycin. And if the triglycerides personally is more than 200, you can add fenofibrate or omega-3 fatty acids. So there is diet as a praying role. So diet for at least a period of 3 to 6 months has to be emphasized, and check whether the BMI is decreasing. If it is decreasing, we can control with diet itself. Students, in today's session, we discussed about metabolic syndrome, the components, the clinical manifestations, the complications, and evaluation and management of metabolic syndrome.